Good morning. Tissue repair. Tissue repair is the final section in the chapter that is inflammation and repair. I think it's a very straightforward chapter or straightforward section. So hopefully this class will make things easier to remember for you. I apologize for any audio disturbances because today seems to be a very thunderstorm day. In any case, we do know that repair is the final step of inflammation, the inflammatory process. In fact, the other steps of inflammation lead to or are the cause of repair for starting. Repair is the same as healing. Usually we use the word healing to mean tissue repair when it's on the surface, like surface epithelia, skin, and repair for parenchyma or solid organs. However, both terms can be used interchangeably. And in any case, they just mean that the tissue architecture and tissue function after an injury get regained. So it's the restoration of tissue architecture and function. Repair in any case involves two processes, two reactions, regeneration and scar formation. So the way I think of this entire section, I guess, is kind of like a 5-song album. We have intro repair, then we have the two main singles, regeneration and scar formation. After that, we have the factors that affect tissue repair, and then finally we have outro clinical. So just to define these two reactions, regeneration means there's replacement of the damaged tissue with regain of function. This depends on the ability of that tissue to regenerate, whereas scar formation does not have any regain of function. Instead, there's just patchwork repair of that injury by deposition of connective tissue. So this connective tissue may give enough structural stability that the little regeneration that is there will allow the organ to function almost normally. However, there is no regain of function in the places which are replaced by connective tissue. So in actuality, whatever injury you have, both processes take place. You have both regeneration and scar formation. Depending on the type of the tissue and the type of the injury and many other factors, you have different degrees of regeneration and scar formation. Some injuries may have almost entirely scar formation. Other injuries may be almost entirely regenerated. And both of these reactions require cell interaction with extracellular matrix and growth factors, cytokines. These are all concepts that we'll be learning and I'll be describing in later sections. And both reactions involve proliferation of cells. When the cells are that of the tissue itself, that is regeneration, whereas if the cells are vascular, blood vessel cells, or fibroblasts, that is connected to scar formation. Before we actually dive into regeneration, we're going to learn a concept that is very much connected to regeneration, which is intrinsic proliferative capacity. I said that regeneration depends on the ability of the tissue to regenerate itself. That is intrinsic proliferative capacity. Intrinsic proliferative capacity is the ability of tissues to repair themselves. So based on this, we can divide all of the tissues of the body into three types. Truly, different tissues of the body have these three types of cells in varying amounts. So we cannot easily say one tissue is entirely one of the three, but still we've divided them into three. The three are labile, stable, and permanent tissues. So the labile tissues are those that are continuously replacing themselves. For example, we know that the skin cells are continuously being lost and continuously being replaced. Other surface epithelia of the oral cavity, the vaginal anal canal, then you have exocrine ducts like that of the salivary gland, transitional epithelium of the urinary tract, columnar epithelium, of the GIT, of the uterus, of the fallopian tubes. These are all undergoing continuous wear and tear. Because of this very reason, they're continuously dividing and resynthesizing. Similarly, hematopoietic cells of the bone marrow are continuously replacing themselves from the stem cells itself. So the stem cells will divide, proliferate, and differentiate continuously. Such tissues are labile tissues. Stable tissues, they in normal situations are not dividing. Instead, they are in normal situations they do not divide. Instead, when they are injured, they have the capacity to divide. What this means is most of the cells in stable tissues are actually in the G0 phase of the cell cycle. And only very few cells in that tissue are stem cells. These stem cells have the ability to divide, but the rest are quiescent until there is a signal from injury, or as a response to injury, they may enter into the cell cycle. This includes endothelium of vascular tissue, then fibroblasts, smooth muscle cells. These are all tissues that are stable, which means they are not continuously dividing, but they can in times of need. And then the parenchyma of most solid organs like pancreas, liver, kidney, and even adrenals, many other solid organs have this capacity to divide in times of need. Of this, we can kind of divide them into two categories. Liver is a separate category on its own. It has a very high capacity to regenerate, unlike the other solid organs, which have the capacity to regenerate, but not to that extent. Finally, the permanent tissues are terminally differentiated. They are non-proliferative. They cannot divide, not even in times of injury. So, these are most of the neurons, most of the cardiac cells, and even skeletal muscle is considered to be permanent tissues. However, the skeletal muscle sheaths contain satellite cells, and these satellite cells of the endomysium have the ability to produce skeletal muscle elements. Similarly, few areas of the brain also have some limited capacity for regeneration. There's even studies coming out about how the cardiac myocardium may have some limited capacity for regeneration. Sorry about that. So far we've discussed mainly intro repair. That is, repair is the same as healing. Repair involves two processes. Those two processes are regeneration and scar formation. Regeneration is dependent on intrinsic proliferative capacity, and the intrinsic proliferative capacity divides the tissues of the body into three: labile, stable, permanent. If you're asked about tissue repair, I would say this diagram now in the middle of the screen is very important. That is how a tissue may enter into either regeneration or scar formation. Definitely draw it. If it's a mild or superficial injury, it can probably proceed through entirely regeneration. Whereas if it's a severe injury, it's most likely going to enter into scar formation. You can see the difference there, how only the superficial layer of epithelia is affected in the mild superficial injury, and then all of those cells are regained, whereas in scar formation there is blood vessels and deposition of connective tissue. Now let's move on to one of the major sections, regeneration. In regeneration, we will be learning about mainly the growth factors and signals that affect regeneration, and then the actual mechanism of regeneration. Finally, we will end on the note of liver regeneration, because liver regeneration is something that we have a good deal of research on. On regeneration, first of all, it is replacement of injured tissue in such a way that it's through cell proliferation, not by deposition of structural elements like connective tissue. This is dependent on growth factors and the integrity of the extracellular matrix. And there's also the involvement of stem cells that can differentiate into mature cells. So you have proliferation, which is cells dividing, but also some differentiation from the stem cells itself in varying degrees. Moving on to the cell proliferation. The cell proliferation signals, we have mainly two controls: growth factors and integrins. I mentioned that we have to have integrity of the extracellular matrix. That is where integrins play a role. Integrins bind the cells to the extracellular matrix and then create signals for proliferation. Without the extracellular matrix intact, these signals will not be produced. Growth factors, they're produced by many different cells that will be found at the site of injury, especially those cells that are there due to inflammation, because we know repair is the final step of inflammation. This includes alternatively activated macrophages. Alternatively activated macrophages are M2 macrophages. M1 means classically activated macrophages. So always think M2 is the final one, the final step. It's for repair. M1 is for killing, to clear the damage that is caused by our offending agents. And then you have even epithelial and stromal cells, to a lesser degree, can also produce growth factors. These growth factors may bind to extracellular matrix and concentrate near that site of injury, and they activate signaling pathways within these cells. We have studied this many times before, how growth factors lead to transcription and drive the cells through cell cycle. In any case, different signaling pathways are triggered. This leads to transcriptional level changes. Proteins are produced which will either release the cell cycle controls or enhance cell cycle advancement. And then integrins. Integrins are those, I guess, they are found on the surface of the cell, and these help binding of the cell to the extracellular matrix, and thus producing signals for cell proliferation. There are also signaling molecules, I guess you could say. And then to the meat of regeneration, which is the mechanism. The mechanism of tissue regeneration is different for different types of tissues, which is why we spoke about intrinsic proliferative capacity earlier. In labile tissues, it's very straightforward. If you have an injury to skin or you have an injury in the intestine, there's rapid replacement, and there's rapid replacement both by the continuously dividing cells that are already replacing themselves continuously, and then you have some basal cells or stem cells which may be present that can also differentiate into mature cells. This only happens if the basement membrane is intact. If even the basement membrane is lost, you may have incomplete regeneration. Here the growth factors are not quite defined, meaning that scientists have not entirely found out which growth factors are responsible for all of this. There is reduced, and there is another situation where you can have a tissue regeneration in terms of labile tissues, which is, we mentioned, hematopoietic stem cells. If there is a reduced number of blood cells, then our body has several systems, check and balance systems in place, so that colony stimulating factors will get produced, and the colony stimulating factors act as the growth factors in this situation that lead to proliferation of hematopoietic cells in our bone marrow, and therefore we can replenish those blood cells that are missing or in reduced numbers. In parenchymal organs, that is, in organs that have stable cell populations, but we are avoiding vascular stable cell populations and connective tissue stable cell populations. Instead, if we are talking about pancreas, adrenals, thyroid, lung, and even the kidney, in all of these there is limited regeneration. For example, if there is a surgical resection of the kidney, there will be compensatory hypertrophy or hyperplasia in the other kidney. We don't entirely know why this happens. However, it is thought to be local growth factors and other extracellular matrix components that interact and cause hypertrophy and hyperplasia, especially of the PCT of the kidney that remains. So it's well known that living donors of kidneys can survive with the one kidney. However, it's also noted that that one kidney will enlarge in size. The liver is, as I mentioned earlier, a special organ in that you have much greater capacity for regeneration. In fact, up to 90% of the liver can be taken out, resected, and then completely regenerated. That's why living donors for hepatic transplants are said to be very successful. One thing that I have to mention before we jump into liver regeneration is that all of this works best when there is no continuous injury, meaning if there is structurally intact residual tissue. For example, if it was a surgical resection of the kidney or surgical resection of one of the lobes of the liver, if there is continuous infection or inflammation, this will lead to more scarring than simply regeneration. Regeneration alone will not suffice. An example of this is in case of liver abscess. You cannot get that 90% regeneration because there will be a collapse of the reticular network. So there will be scarring. Liver regeneration. Before we jump into this, just to again brush over what we looked at so far, we had intro repair, then we started regeneration. In regeneration, we talked about growth factors and integrins, and then we talked about the mechanism in labile tissues and the mechanism in stable tissues, specifically the stable tissues other than the liver. About liver regeneration, I found it interesting. I think 1 week ago, I read an article, I think it was by a Malayali writer, about how women tend to have disproportionately higher instances of being living donors, to the point where even doctors have reported that they would say that since women are often told to donate their liver in case a family member needs a liver, rather than ask, they have even offered to say that they said things that they have said that they can reject or make up a reason for rejection in case the woman in question really does not want to go through the operation. Basically, gender bias in organ donation or organ transplant donation. And I guess the concept there was how women don't have to go out and work in most households, so they're told that their liver can be donated, they can stay home and convalesce. Anyway, I digress. However, maybe you'll remember that story when you remember liver regeneration. For liver regeneration, we just need to remember 2 points. Number 1, proliferation of the hepatocytes themselves, and number 2, the stem cells. We mentioned this in labile tissues, how you can have proliferation of the continuously dividing or ready to divide cells, and then you have some stem cells that are lying in wait that can differentiate from stem cell to mature cell. So as we said in liver regeneration, extraordinary capacity to regenerate, up to 90% can be regenerated provided it is surgical resection and there is no continuous inflammation or infection. For the proliferation of remaining hepatocytes, you study this in 3 phases. So if you can't remember anything, just write proliferation of hepatocytes occurs in 3 stages. You have priming, cell proliferation, and termination. Priming is when macrophages tend to be the ones to give these growth factors throughout tissue repair. If you can't remember, just know macrophages are the ones that produce the growth factors in general. So the macrophages of the liver are Kupffer cells. Kupffer cells, here you can see in the diagram there's a sinusoid. Projecting into the sinusoid you have the Kupffer cell. Kupffer cell then is separated from the hepatocytes by the small space of this, and the Kupffer cell will produce interleukin IL-6, which will prime the hepatocytes to make them competent for the major growth factors, and this is a process which will convert them from the quiescent G0 stage to G1 stage. And this can take several hours. It's, I guess, one of the almost like the rate limiting step in chemistry. Here, after it gets primed, now we have different growth factors. You have endothelial growth factor EGF, transforming growth factor alpha, which bind to the EGF receptor, and then you have a hepatocyte growth factor binding to MET. These all cause the entry of the hepatocytes into the cell cycle proper. So now they can proliferate, which is the second step. And then the third phase is termination, which after much proliferation, there are some unknown signals which will lead to the termination of cell proliferation. We think it might be transforming growth factor beta, but there is no real confirmation or enough confirmation of that. So cell proliferation in liver regeneration is priming to take the cell from G0 to G1, and then you have EGF, TGF alpha, HGF causing the cells to enter the cell cycle properly, cell proliferation, termination. From the progenitor cells, that is the stem cells, after chronic liver injury or inflammation, there's more involvement of the stem cells than merely the hepatocytes. Otherwise, it's mostly the hepatocytes. Okay, if it's surgery, it's almost 100% hepatocytes that cause this regeneration. The progenitor cells tend to occupy specialized niches, and I think I didn't mention this before, but these stem cells tend to occupy specialized niches from which they may leave and differentiate and become mature cells. Here the progenitor cells of the liver are known as oval cells, but oval cells are called as such because they were studied in mice and they had that oval shaped nucleus. However, in humans, I think it's just better to call them progenitor cells. They occupy the canals of herring. Canals of herring are these very small niches, very small canals, which are seen at the junction of bile canaliculi, where they drain into the bile ducts. And again, we have unknown signals that will trigger the stem cells into differentiation, and it's a key area of research right now. Moving on to scar formation, our second main topic. Just to recapitulate, in regeneration, we studied growth factors, integrins. We studied the mechanism in labile tissue, in stable tissues, and then liver specially. And liver specially, we had two major points. Scar formation. Scar formation, otherwise known as connective tissue deposition, is when regeneration alone is not possible. And even though we say this, again, keep in mind that for whatever injury, you have both. You have both scar formation and regeneration occurring. Regeneration is not enough would happen due to either severe injury, chronic injury, injury to the connective tissue framework of the organ itself, or if there's injury to permanent tissues. As we said before, permanent tissues like the cardiac myocytes, they cannot regenerate. So for these 4 reasons, you get scar formation. Here, the injured cells get replaced not with functional cells, but connective tissue. Therefore, you get almost like patching. For scar formation, we will study the steps of scar formation, which are 3. We have a important short note, I guess, which is granulation tissue. Granulation tissue should not be confused with granulomatous tissue or granulomatous inflammation, which is from our chronic inflammation section. And in the sections of steps of scar formation, we have angiogenesis, then we have the deposition of connective tissue, and then we have remodeling of connective tissue. So, discussing these in detail. The steps of scar formation. In general, if they just ask you the question, steps of scar formation, it might be best to write from normal tissue onwards. That is, you have a normal tissue, it undergoes some tissue injury. The tissue injury will lead to the response that is known as inflammation. Inflammation will cause formation of granulation tissue and then scar formation. Describing the actual repair steps there in detail, you have angiogenesis. Angiogenesis is the formation of new blood vessels which will supply nutrients, supply oxygen, which are required for repair. And because of this increased supply and increased vascular permeability, which is due to VEGF, which we will study in detail just in a moment, there will be edema that may persist even long after inflammation is done. So repair comes after inflammation. You may have edema with inflammation, but then even after the inflammation is done, you might find swelling in that organ or in that injury area, and that is due to angiogenesis. And then you have deposition of connective tissue itself. The second step, some people write as formation of granulation tissue. That's also correct. However, I grouped angiogenesis and deposition of connective tissue together because in actuality, granulation tissue is deposition of connective tissue after angiogenesis has taken place. So they are tied together. And then you have remodeling of that connective tissue, which involves maturation of the connective tissue elements and reorganization that will finally produce a fibrous scar formation. I mentioned granulation tissue before. So what is granulation tissue? Granulation tissue, first you have the angiogenesis, meaning you have blood vessels. There's blood vessels in that tissue, numerous. Then you have some loose connective tissue that has been deposited by fibroblasts that have migrated and proliferative. And then you have some remaining leukocytes there from the inflammation. Final steps of inflammation. So there are 4 elements to granulation tissue that you must remember. Blood vessels, fibroblasts that have migrated and proliferated, loose connective tissue, and then leukocytes. These form granulation tissue. The reason why it's called granulation tissue is its gross appearance looks granular. It's soft, pink. I think the best way for you to remember, most people know what it is, but if you have a deep wound, you might see that pink gross appearance, especially if you pick the scab off. Suppose you get a wound and then you have the darker brown scab, which is due to drying out of the external clot and external elements of repair. Underneath you get that soft pink granular tissue. That is granulation tissue. Histologically, you have the appearance of numerous thin-walled capillaries that are very fragile. You have proliferation of fibroblasts in varying stages, loose extracellular matrix elements which include collagenous, loosely dispersed, some elastic fibers, and many inflammatory cells, especially macrophages. Depending on the size of the injury and the intensity of inflammation, you have varying degrees of granulation tissue per wound. Not to be confused with granulomatous. Granulomatous tissue or granulomatous inflammation is a type of chronic inflammation where you have aggregation of macrophages around a central necrosis. So keep that separate. Granuloma, when you hear loma, think it's chronic inflammation. Macrophages. Just to mention macrophages in detail once again, they play a very central role in repair as well. However, usually it's the M2, alternatively activated macrophages that are involved in repair. They did help in clearing before. That one is mainly M1. You do need clearing of the different debris before you can have repair. Then they also provide growth factors for proliferation, and they provide cytokines for fibroblast proliferation and for the deposition of connective tissue or production of connective tissue from those fibroblasts that have now come and proliferated. To give a time frame, you have repair generally begins after 24 hours after injury. When I say it begins after 24 hours after injury, that's when you start to see fibroblasts in the area and more migration, more and more cytokines, growth factors acting upon these different elements. So I drew on the side fibroblast emigration. So that's 1 day after the injury. And then you have, by 3 to 5 days, more granulation tissue are forming. So these are the two points to remember. These 2 points become more important when we're talking clinically. It's still 2 points that are useful benchmarks to remember. 1 day after, you have fibroblasts. 3 to 5 days after, granulation tissue. So that was kind of the intro section of scar formation. What is granulation tissue? And then the steps of scar formation. Now we can go into each step of scar formation in detail. Angiogenesis. Angiogenesis is the production of new blood vessels from existing vessels. It occurs obviously in repair, that's why we're talking about it here. However, we also have angiogenesis in collateral circulation. When you have an ischemic tissue, there may be development of collateral circulation without actual injury to the tissue, for example, in the heart. And then you can have, in tumors, we also have angiogenesis, a very important step to understand tumors. And this is why we want to understand angiogenesis very well, because if we know how to decrease angiogenesis, we can maybe control tumors. And if we know how to enhance angiogenesis, maybe we can help out ischemic heart or angina, that kind of situations. Anyway, coming back to repair, look at this diagram here. If you can draw this diagram and explain this diagram, now you have angiogenesis. What do you notice? First, you have on the left a quiescent vessel, that is a dormant normal vessel. Quiescent means sleeping almost. So the sleeping vessel, it's narrow, there's pericytes, there's endothelium, and in between you have the basement membrane. When there is appropriate activation by various factors, now you notice, first thing you notice is it's wide, meaning vasodilation happened. The pericytes have peeled off the sides, so now the basement membrane can degrade. Then you notice in the right side middle a leading tip cell that is poking out and growing outward to form a new blood vessel. In brackets I've written VEGF and notch signals that will come into play later. I will explain that in detail later. Just behind these leading tip cells, in the next scene, you will see again those leading tip cells are in the center from two different blood vessels. You have two different branches growing out, two different leading tip cells in the center that are tangled up extracellular matrix components in between. The other endothelial cells have followed just behind this leading tip cell. You have parasites that have been recruited and are also coming just behind, and you have a proper tube now forming, the properly shaped blood vessel. Finally, you will get the formation of a new vessel. So I've just explained the steps of angiogenesis there. You have vasodilation. Here, VEGF, vascular endothelial growth factor, induces permeability and the production of nitric oxide. So this will lead to edema, and it will also lead to just general vasodilation, which will allow greater supply of blood and greater perfusion that is required to form a new blood vessel. Then you have separation of parasites from the abluminal outside lumen surface and basement membrane breakdown in between. Migration of the endothelial cells towards the area of injury is the next step, which is that leading tip cell, which is dependent on Notch signaling and VEGF, I mentioned before, and then the other endothelial cells proliferate just behind the tip. You have remodeling into proper tubes now, capillary tubes, not just a collection of cells. We don't want a string of cells proliferating. We want proper tubes. Periendothelial recruitment occurs. Periendothelial recruitment means the parasites get recruited. We say parasites, however, oh, I am so sorry. However, in case of larger vessels, this involves also smooth muscle cells, not merely parasites. So smooth muscle cells can also get recruited. And then you have suppression or termination. Again, suppression of the endothelial proliferation and basement membrane gets deposited, completing the new blood vessel formation. So the steps of angiogenesis, just write them as you know. If you have the diagram, then just write them in the natural order they are. That's it. Then you have the factors that are involved. Here we have the growth factors, Notch signaling, extracellular matrix, and enzymes, specifically matrix metalloproteinases. These are the four factors that are involved. So in angiogenesis, we studied the definition of angiogenesis, then that diagram with the steps of angiogenesis, and now the four factors that contribute to angiogenesis. The four factors are, first, growth factors. Growth factors, we have VEGFs, especially VEGF-A. VEGF-A stimulates migration and proliferation of the endothelia. That was that leading tip. Under the leading tip cell, I wrote in bracket VEGF. Then you have vasodilation by nitric oxide production, which is also due to VEGF, and lumens get formed. So capillary tube formation also actually. Then you have FGF. FGF is fibroblast growth factor, especially FGF2. This also leads to proliferation of endothelial cells. Migration of macrophages and fibroblasts is also stimulated by this guy. And then you have stimulation of epithelial cells migrating for epidermal wounds. So it's actually not purely just angiogenesis. You also have macrophages, fibroblasts are called to the site of injury, and if it's an injury on the skin or epidermis, then you have epithelial cells are brought over so that it can close up the wound. Angiopoietins, angiopoietin 1 and angiopoietin 2 especially, these help in structural maturation of the blood vessels. They do so by stabilizing the stabilization of these newly formed blood vessels through parasite recruitment and then deposition of connective tissue. This is done by interaction with a tyrosine kinase receptor on the cells known as TIE2, TIE2. I don't think it's that important. Just know that you have angiopoietin, which is shortened as ANG1 and ANG2. These are involved in maturation of the structure of the blood vessels by bringing parasites to hold that structure together. Another important growth factor which is used for structural maturation or stabilization is this PDGF, platelet-derived growth factor, and transforming growth factor beta. Platelet-derived growth factor helps in smooth muscle recruitment, and TGF-beta suppresses endothelial proliferation and enhances extracellular matrix production, thereby leading to stabilization or almost a resolution, termination of our angiogenesis. That last step, suppression of endothelial proliferation and basement membrane deposition, gets connected to our last growth factor here, TGF-beta. Now, notch signaling. What is notch signaling? Notch signaling is, I put it here under the leading tip in bracket. It's simply a crosstalk between various elements that are involved in angiogenesis, various cells and various signaling molecules that will ensure that new vessels have proper spacing for effective supply to the healing tissue. So making sure that two leading tips won't block each other or cross each other, or you don't get too many vessels in one area and not enough vessels in another area. They just communicate to ensure that the newly formed vessels are spaced properly. Then you have extracellular matrix. This is again through our integrins, through interactions with the cells and the extracellular matrix. And the extracellular matrix also helps provide scaffolding. Scaffolding means like a framework for vessels to grow. Finally, our matrix metalloproteinases. Matrix metalloproteinases break down the extracellular matrix, so we have a space for the vessels to extend, for the tube of the vessel to extend further out. We will learn about matrix metalloproteinases in detail in later section, but this is how they come into play in angiogenesis. So the first step of scar formation is done, angiogenesis. Now, to form granulation tissue, on top of our angiogenesis, we need connective tissue. Connective tissue involves two main steps. You have the fibroblasts that must come into that site of injury, migrate, and then proliferate. We said that happened on which day? Yes, that happened on day 1. That is after 24 hours. And then you have the deposition of extracellular matrix proteins or components, especially collagen, fibronectin. Collagen starts with type 1, and then by the end it gets replaced by type 3 mainly. This is all done by these same fibroblasts, so that comes as the second step. Again, this involves locally produced cytokines and growth factors. Here the growth factors involved are platelet-derived growth factor. Remember, in angiogenesis we learned that it is involved in smooth muscle cell recruitment. FGF2, again, it is involved. This is fibroblast growth factor 2, and we talked about how they help in the migration of macrophages, fibroblasts, and even epithelial cells to the site of injury. And then you have transforming growth factor beta, which plays a very big role in the second step, formation of granulation tissue. All of these guys come again from our M2 macrophages especially, but then you can also write lymphocytes and mast cells very confidently. Just write macrophages and lymphocytes. These are the two main cells that are involved when it comes to growth factors in inflammation and repair. Transforming growth factor beta. We'll discuss this one in detail because it is the most important growth factor involved in granulation tissue. It's produced by most of the cells in granulation tissue, especially our macrophages, and it is regulated mainly through post-transcriptional activation and secretion, meaning that there is not Unlike our signaling pathways from the other growth factors before, we talked about how at a transcriptional level they will increase the production of the proteins. Here, this is already heavily produced. However, it needs to be activated, and the secretion, it's stored in the cells. So this injury will lead to increased secretion of this transforming growth factor beta. And integrins can also enhance or decrease the activation of this TGF beta. So this integrins also play a role in regulating the activity of TGF beta. The functions of this are, number one, stimulates fibroblast migration and the proliferation of fibroblasts. Then you have increased deposition of the extracellular matrix elements from these fibroblasts, that is increased collagen and fibronectin synthesis. And it also inhibits matrix metalloproteinases, thereby decreasing the extracellular matrix degradation. Finally, TGF-beta is also an anti-inflammatory cytokine. It will inhibit the proliferation of lymphocytes and just in general inhibit the activity of all leukocytes. So it has its own studies in anti-inflammatory purposes as well. But in repair, it acts as an ending, a concluder. It is involved in fibrosis of different internal organs like the lung, liver, and kidney, as well as scar formation. So scar formation and fibrosis can almost be used interchangeably, but we'll discuss fibrosis in detail later. Coming back to scar formation, the deposition of connective tissue, through these various growth factors that we have mentioned, PDGF, FGF2, and TGF-beta, you have more fibroblasts migrating to the site. They are proliferating at the site, and they are depositing collagen and fibronectin and various other elements at this site. Later, these fibroblasts will attain a more synthetic phenotype, meaning that they will slowly stop to proliferate as much, and you will find less cellularity. Instead, there will be increased extracellular matrix deposition. The granulation tissue evolves to become a scar, a fibrous scar that has inactive spindle-shaped fibroblasts, dense collagen, no longer loose collagen. Loose collagen is a feature of granulation tissue. Here it is becoming more and more like a scar. There's elastin fragments, then extracellular matrix components, and it is mostly avascular as well. Here, you may even find some of the fibroblasts have become myofibroblasts. So what is a myofibroblast? Myofibroblast is fibroblasts that acquire smooth muscle cell features, specifically actin filaments especially, and this will give it the ability to contract. So you have scar contraction. Many scars can contract to up to 5 to 10% of what they were originally, within just a few weeks. We'll learn that again later. Now we have the final step of scar formation. We discussed angiogenesis, that diagram, the steps and the factors that are involved. Then we had the 2 steps of connective tissue deposition, granulation tissue formation, and TGF-beta. And then now you have remodeling of the connective tissue into a proper, that is the final step of scar formation. Here you can see in my notes that I've taken these last 2 points of the previous section and also drawn an arrow into this section. The reason why is, if you're just asked remodeling of connective tissue, there's almost an overlap. These 2 points can also come here. Basically, the fibroblasts are now more and more synthetic. They synthesize extracellular matrix components. They are not proliferating, and there may be scar contraction. So this remodeling happens as a balance between synthesis and then degradation of the existing. That's how we get remodeling. We mentioned before that remodeling, and I can go back here. Remodeling is simply maturation and reorganization to produce a fibrous scar from the granulation tissue. So maturation just meant that the fibroblasts are now matured in a new phenotype, and reorganization happens by degrading some of the existing extracellular matrix that has been deposited, and then new synthesis. And so this continued modification and remodeling can occur. This is mainly balanced by two different enzymes. We have matrix metalloproteinases and then ADAMS, Adams. Going to MMPs. Matrix metalloproteinases. Metallo should make you think zinc. Proteinases, there are other proteinases. Don't confuse with serine proteinases. We have other plasmin, then some gelatinases from the neutrophils. There are different proteinases, even at the site of injury, that are coming from inflammation side. But in repair, you have mainly metalloproteinases, which are proteinases that depend on the metal ion of zinc. These include three main categories. You have interstitial collagenases, gelatinases, and stromalysins. Interstitial collagenases will degrade fibrillar collagen. Then you have amorphous collagen, which will get degraded by gelatinases. And then you have various different extracellular matrix components. The different collagens, especially amorphous collagen, and then proteoglycans, laminin, fibronectin. All of these four can get degraded by stromalysins. Stromalysins include 3, 10, 11. Interstitial collagenation is 1, 2, 3. And then gelatinases are matrix metalloproteinases 2 and 9. I did mention that gelatinases, along with amorphous collagen, it can degrade fibronectin as well. So basically, metalloproteinases are proteinases dependent on zinc that can degrade extracellular matrix components, like especially collagen. They are produced by fibroblasts, but also macrophages, synovial cells, epithelial cells, etc. They are very tightly controlled. We did mention, I don't know if you remember, MMPs get inhibited by our transforming growth factor beta. But our transforming growth factor beta has different functions, stimulating the fibroblasts to come form the granulation tissue, and they also prevent the degradation of extracellular matrix components by these matrix metalloproteinases. But then you have other control systems on these enzymes, which include different cytokines and growth factors. That's where that TGF-beta comes. And then these enzymes are secreted as zymogens to begin with, meaning they are secreted as precursor molecules. And these precursor molecules must be activated by another enzyme, plasmin. Plasmin is a serine proteinase that is secreted from the different inflammatory cells, meaning that this enzyme will only be seen at a site of injury. So it's because an injury is there that we have plasmin formed, and because plasmin is formed, it can break this zymogen to cause this degradation of extracellular matrix components. Otherwise, we would just have digestion of various extracellular matrix components throughout the body at all times, which is pathological. Now, then, one very important inhibitor of MMPs that you should write down is it is inhibited by TIMPs. MMPs inhibited by TIMPs. TIMP stands for tissue inhibitors of metalloproteinases. These usually come from mesenchymal cells, and so we can kind of say that the remodeling of connective tissue in general is a balance between MMPs and TIMPs. To vastly simplify, the other player that we mentioned other than MMPs was ADAMS. ADAMS stands for A disintegrin and metalloproteinase, ADAM. These are anchored to the cell membrane of the cells, and they can cleave and release extracellular domains of cytokines and growth factors, and thereby lead to a ending stage of our repair. And so we have now covered the major portion of tissue repair. Take a moment to recollect and breathe. Good job. So far we have discussed the introduction to repair, which is the definition of repair, the two processes that are involved in repair, and then the fact that growth factors, extracellular matrix interaction is all involved. We then went into those two reactions or processes that are involved in tissue repair in detail. Now we are moving on to the fourth track in this 5-song EP. The third track is very short, so don't worry. Filler maybe. So this is just the factors that influence tissue repair. These factors can be understood as extrinsic or intrinsic and local or systemic. So what do I mean by factors that influence tissue repair? What factors can prolong tissue repair, can hasten tissue repair, and these can come from outside, can be within, it can be at the local site of injury, or it can be a systemic cause. You should first and foremost mention infection. If there is an infection, it will prolong the inflammation. It may increase tissue injury, and it will lead to more scarring. Diabetes mellitus is one of the most important systemic causes for prolongation of tissue repair. In fact, even in the current situation, when it comes to the coronavirus, diabetic patients are risk patients because they have a harder time recuperating. Excuse me. Oh, that's not good. Me talking about the coronavirus and then coughing. It's because I have a dry throat. Anyway, the next factor would be nutrition. Protein deficiency, vitamin C deficiency lead to prolongation of tissue repair. Glucocorticoids, especially steroids in general, steroids that are prescribed for various reasons, they act as anti-inflammatory, and so they inhibit TGF-beta and will lead to a weaker scar, less fibrosis perhaps, but just in general a weaker scar. So it will prolong and weaken tissue repair, but this may be useful in terms of or in regards to corneal infections, especially because in corneal infections prescription of glucocorticoids or steroids can prevent opacity. So with less fibrosis of the cornea, less chance for opacity. Mechanical factors: local pressure on the injury, torsion of the injury, dehiscence is all connected to mechanical factors. If there's poor perfusion, this can be either on the supply side or the drainage side. Arteriosclerosis, diabetes mellitus can all lead to poor supply. Obstructed venous drainage, like in varicose veins, can lead to, again, poor perfusion, which will prolong tissue repair. Foreign bodies, glass, bullet, whatever, steel, they can all hinder tissue repair. The type of tissue and the extent of the injury we discussed before, and then the location of the injury all play a role in tissue repair. The location of the injury, one point that the textbook, our Robbins textbook, goes into detail is inflammation in tissue spaces. When they say tissue spaces, they mean cavities, like our pleural cavity, the peritoneal cavity, even the synovial joint cavities. Here, inflammation will lead to mass production of exudates, fluid, right? And so in this fluid, you can either have clearing of the fluid, which is resolution in repair, and then repair, or you can have the repair happening into the exudates. That is, the granulation tissue will form amongst the exudates, and that is organization. So after repair of inflammation in tissue spaces can go either two routes. One of either two routes. It can either be resolution, or it can go into organization. Remember, resolution is clearing of the exudates before in repair, whereas organization means the granulation tissue is forming within the exudates in that tissue space. Organization, I doubt they'll ask this way, because organization, remember, is also involved in our outcomes of a thrombus. So don't get confused with that organization. Now we have the final outro track. So in factors that affect tissue repair: infection, diabetes, nutrition. So that's one local, two systemic. Then you have steroids, mechanical factors, poor perfusion, foreign bodies, the type of tissue, the type of injury, and the location. Now, healing of skin wounds. In clinical aspects to tissue repair, we will be talking about skin wounds, then we will talk about parenchymal organs. We will just mention wound strength, which is a question that is more connected to surgery. Actually, this entire section is very surgery clinical posting. I guess it does play a role in more the MCQ side, maybe. PG entrance, that side. Not really important for our second year, I would say. And then finally, we have abnormalities of tissue repair. And with that, we will be done with this section. So do not worry. Let's go into healing of skin wounds. Healing of skin wounds, you have healing by first intention and healing by second intention. First intention means that the dermal surfaces can be approximated or are approximated. Meaning, if you have a wound, again, we're talking about skin wounds. Remember that. When we have a skin wound where the edges of the wound can be closed together and they are held together, that is known as primary closure. For example, a surgical incision that we suture. If we suture that incision, that is the primary closure, and then it will heal by primary union or first intention. These are first intention, primary union, both mean the same thing. Secondary intention is, suppose you have a wound where you cannot bring the two edges together. So instead, from the bottom up, the healing must rise up to the level of the skin, right? That is healing by secondary intention. It's healing by second intention. Do not say secondary intention. So in first intention, this involves mainly epithelial regeneration. Of course, some scar formation will be there. And most importantly, you should mention the example. If they ask you what's healing by first intention, healing by second intention, mention example of first intention would be an approximated surgical incision. Second intention would be a large ulcer, abscess, or wound. You can see in this diagram that I've drawn, on the first intention side, you have an incision and the dermal edges can be approximated. In the second intention, from the bottom, it must grow up and it rarely reaches the same level of the skin, the surrounding skin. It will be just a bit lower usually. We mentioned before 24 hours, what happens? Fibroblast migration. What happens day 3-5? Granulation tissue. Same thing. Here, this is again more surgery posting, so it's very unlikely they will ask this. But just in case, you should just mention the different things we have learned so far. Wounding will lead to a clot formation. Clot formation will have trapped RBCs, fibronectin, all that. But mainly, you'll also have a lot of growth factors and chemokines that come into play. VEGF will be secreted. This will lead to edema, increased vascular permeability, and now you will have more and more perfusion in that area. Scab forms up top because there is drying out of those external elements, dehydration there, whereas in the lower areas of the wound, below the scab, you will have neutrophils that have infiltrated. Granulation tissue forms. Granulation tissue reaches a peak. The epidermis recovers to its normal thickness, and then in the following weeks there is continued collagen deposition, decreased cellularity, and finally it will become almost avascular, and there will be blanching of the scar. It will turn white. So this is a fairly straightforward process. Even though the scar may fully disappear to the extent where it looks like it has regained the same epidermis quality, the dermal appendages will be lost, meaning that our hair won't grow there, receptors will be maybe lost, such things. Back to second intention. Here, the differences is that the fibrin clot will be much larger because it's a larger wound. The inflammation will be more intense. The secondary injury, therefore, is more likely. You can have, because it's a large wound, you can have secondary infection. But even if it's not infection, you can have a secondary injury that is immunogenic in nature. There's greater amounts of granulation tissue that will be formed, therefore a larger mass scar, which will often involve a lot of wound contraction, and thereby there is a greater role of myofibroblasts in our healing by second intention. Wound strength, tensile strength of a wound is a very surgery topic. Wound strength, when you have a carefully sutured wound, it can gain at max 70 to 80% of the normal strength of skin. By 3 months, it gains that strength. And after 3 months, there isn't much improvement in tensile strength. At 1 week, it is only 10% of the strength, but then in the next 4 weeks, that tensile strength will increase rapidly because there is collagen degradation and modification and increased deposition. Crosslinks especially will form in the collagen, and then it will finally regain that 70 to 80% strength. Now, fibrosis in parenchymal organs. We mentioned this before. Fibrosis can actually be used interchangeably with the term scar formation. They both mean same thing in general. However, usually when we say fibrosis, we mean the abnormal deposition of collagen in internal organs, especially in chronic diseases. So it's a pathological process, and this happens when there's persistent injury in those internal organs, mainly in chronic infection, but also in immunological diseases. It has the exact same basic mechanism of scar formation. So you can draw this diagram. You have our epithelia. The epithelia undergo tissue injury. There is thus loss of integrity of the epithelia. If it's a limited injury, it can get regenerated and then return to normal. But if the injury continues and there is repeated injury or severe injury, especially repeated injury, which is what happens in chronic infection or immunological diseases, then it goes into inflammation. Macrophages arrive, lymphocytes, especially T lymphocytes arrive. They produce cytokines, interleukin 13. Macrophages, our M2 macrophages was the one that gave to transforming growth factor beta, matrix metalloproteinases. These growth factors and enzymes and cytokines all act to recruit fibroblasts and produce scars. Myofibroblasts are found, extracellular matrix components get deposited, you get fibrosis. Now, fibrosis in these internal organs, like lung fibrosis, for example, this can generally lead to organ dysfunction, even organ death. So, it is a pathological process. Finally, in the clinical aspects of tissue repair, we have to discuss abnormalities of tissue repair. There are 4 major abnormalities of tissue repair. You have deficient scar formation, excessive scar formation. And then besides excessive scar formation, you can have excessive granulation tissue, and then you can have excessive wound contraction. Going into the 4 in detail, deficient scar formation is when there is not enough granulation tissue. Wound can either undergo dehiscence or ulceration. Wound dehiscence or rupture Especially happens when it's an abdominal surgery suture due to increased intra-abdominal pressure. So this can happen from vomiting or coughing, or if it's a case of ileus, and so there is backup of the food that is not able to pass through, then you can have rupture of the wound of the rupture of the scar, and then you can have ulceration when there is deficient scar formation, and this especially happens when you have poor perfusion, as in atherosclerosis, or if there is, even in cases of diabetic and peripheral neuropathy, because of the lack of the nervous component, you can have subsequent ulceration. Hypertrophic scars and keloids. Keloids is a word they can ask. Hypertrophic scars just means excessive amounts of collagen get deposited, especially if it was a thermal injury. Thermal injury means burns or even cold injury, and also if it's a traumatic injury that affects the deeper layers of the dermis. These two can cause hypertrophic scars. Keloids are hypertrophic scars that go or extend beyond the boundaries of the original wound, and they don't regress. And so you may see those pictures in the textbook of these large raised brown, almost bulbous looking hypertrophic scars. Those are keloids. Proud flesh. Proud flesh is excessive granulation. So you have granulation tissue that protrudes above the level of the skin, and because they're going above the level of the skin, you can't get re-epithelialization. Re-epithelialization, or it prevents re-epithelialization, and therefore surgical excision or cauterization becomes necessary. And very rare, this is a very rare borderline tumor, desmoids or aggressive fibromatosis can form. In this case, there is recurrence after surgical excision, and so you will get more granulation tissue, and radiation, chemotherapy, something like that will become necessary. Finally, wound contractures. Wound contractures is an exaggeration of wound contraction, especially in the palms, soles, or anterior aspect of the thorax. If you have a large wound, there can be extreme contracture, especially if the injury was from burns, and this can affect the range of movement. Palms may not be able to open fully. You may have seen such pictures before. And thereby, we have completed the clinical aspects of tissue repair as well. We had healing by skin wounds, which was healing by first intention and healing by second intention. Then we had wound strength, one point which is the main point there is we can only get 70 to 80%. We can only regain 70 to 80% of the normal strength of the skin there. And then we had fibrosis in parenchymal organs and abnormalities, which are 4. In this entire section, we have gone over, just to quickly rush through, we had what is repair, final step of inflammation, the 2 processes. Then we had intrinsic proliferative capacity. This diagram is important. Know that regeneration, what is regeneration, what factors control it. Then in labile tissue and stable tissues, liver regeneration, scar formation, the steps. Then granulation tissue is a question. Angiogenesis, the first step. Then we have deposition of our connective tissue, formation of granulation tissue. Then you have remodeling of connective tissue, matrix metalloproteinases, TAMPs. The factors that influence tissue repair are filler track, but nonetheless, you should be able to write something there. And then finally, the outro. We are now done with tissue repair. Thank you for your attention, and I hope